Long-acting basal insulin are used for the management of both type 1 and type 2 diabetes mellitus. But why it is so important and how it works and all, to focus all these updates, we have with us an eminent endocrinologist practicing in Kolkata, Dr. Kaushik Sen. And to chair this particular session, I'd like to invite Dr. Mridul Bera, one of the founder member of HDS, and Dr. Shattoki Manna, consultant physician and renowned endocrinologist. Both the chairperson, please come over the stage and introduce our speaker.
Hello. Hello. Now the session is about the insulin. So this is the session about the long-acting insulin, the need of long-acting basal insulin in Indian context. Now, when you just see the diabetic management, and we have transformed our practice into a more patient-centric approach, we have changed that approach from the patient-centric to the glucocentric. Now we are concentrating on the associated complication-centric or the cardiovascular and renal complication-centric approach. Now, talking about this approach, the two things is very, very necessary for the diabetic management. One is the glycemic management, and other is the definitely other cardiovascular, renal, and the other complication managements. Now, still, there is the use of the basal insulin. Use of the insulin is utmost necessary, because for a diabetic management, first of all, you have to improve the glycemic control, and then you have to consider the other aspects. And for the glycemic benefit, for the glycemic management, I think the role of insulin is there in not only in a type 1 diabetic patient, but also the type 2 diabetes mellitus patients. And in the recent years, the long-acting basal insulin has come a long way, because every patient who are on OAD, when the OAD fails, then we need to give the patient the long-acting insulin, because this is on once daily insulin and patient will accept it. Otherwise, you have to give the 2 or 3 injections. To talk about more of this basal insulin, I'm inviting Dr. Kaushik Sen, and who will be speak on the need of long-acting basal insulin, particularly in Indian scenario. Over to Kaushik.
Okay, thank you, sir. Thanks my chairperson for the introduction, one of them being one of my senior colleagues, Dr. Shattoki Manna, was 1 year senior to me during my DM days in IPGMER Kolkata. Thanks, sir. And regards to the Howrah Town Diabetic Study Society for inviting me onto the stage today. As my chairperson, sir, has rightly pointed out, my topic over the next 15-20 minutes or so would be on the basal insulin, specifically in the Indian context. So to put all of us into picture, I have started this one with specifically epidemiological studies. Both of these studies were published in 2020. 2 separate articles. The upper one was an original article, a study design made from Maharashtra itself. They tried to assess mostly the epidemiology of the treatment of diabetes mellitus, specifically type 2 diabetes mellitus in their scenario. And an astonishingly more than 50%, means more than half of the physicians who used to treat the diabetic patients, both who were trained endocrinologists and who were not properly trained, in none of these were treating the patients according to any of the established guidelines then. So it was astonishing. We need to train ourselves in India before we try to treat our patients. And the lower one was Impact India, basically a study by one of the major pharma houses. They tried to assess that in Indian scenario, in about 50% of the type 2 diabetes patients were belonging to HbA1c of more than 9, which is about 2% higher than the established target in most of the diabetic population. So we need to bring down that HbA1c to somewhere around 7, that's the established norm. So that's the burden of the problem today. So coming to the anti-diabetic portfolio regime, we all are aware that insulin is the drug that has got the maximum chance of reducing the HbA1c. There is practically no limit to which insulin could decrease the HbA1c. Of course, keeping apart the risks of hypoglycemia, that is a well-established entity. So with that, what does the ADA standards of medical care suggest? As Sir had rightly pointed out, when the oral anti-diabetic agent fails, it's time for the injectable ones. Well, over the past 5-7 years or so, starting from 2018 algorithm, the first injectable after the oral agents fail would be an injectable GLP-1 receptor agonist. We are not discussing GLP-1 today, but this must be remembered that the first injectable after a MADI failure in most of the guidelines today would be a GLP-1 receptor agonist injectable that has got some limitation, mostly the cost and the GI side effects. But when we are coming to insulin, it should nearly always be a basal insulin. That's the ADA standards of medical care suggest. Now, what is the exact basal insulin to choose among the large portfolio I'll be discussing next is never mentioned. The ADA also mentioned that most of the cases it could be NPH only, but it does also mention that in persons who are having difficulty in taking twice daily insulins, because insulin NPH is essentially a twice daily insulin, being an intermediate acting one, has got a half-life of around 12 to 16 hours. So if a person is having difficulty in taking twice daily basal insulin, or if a person is having recurrent hypoglycemias, it's always preferred to change to a basal insulin analogs. That's the ADA mandate. Now, nearly the same thing is echoed in most of the other guidelines as well. AAC nearly the same, only the algorithm to titrate and initiate prandial insulins differs between ADA and AAC. Essence remains the same, that we should always try to initiate with basal insulin. IDF and RSSDI nearly the same portfolio measures. Coming to next, what are the characteristics of an ideal basal insulin? Essentially, it's given once daily. It restrains the hepatic neoglucogenesis and limits the interprandial excursions of glucose. And as we have already mentioned, that in nearly all the cases it could be NPH only, but in some cases at least the other longer acting analog insulins are preferred. Now we would discuss gradually whether they have actually got any preference over standard NPH insulin, the newer second generation analogs. Now, which amongst the basal insulin to choose? We do have a long list of basal insulin, starting from NPH that was discovered back in 1946. The first intermediate acting insulin, NPH, classically is not considered a long acting insulin. According to the standard textbooks of pharmacology, it's given the name as intermediate acting insulin, has got a half-life of around 12 to 16 hours. Next in turn, we do have the longer acting analogs. In the middle, we have the first generation long acting analogs, insulin glargine 100 and datamid. Datamid has to be given again twice daily, has got a half-life of around 18 hours. But glargine 100 is a good insulin, it's essentially a once daily insulin. That is established. Now amongst the second generation basal analogs, we do have two till date, the glargine U300, a more concentrated insulin, and degludec U100. So these are considered as second generation basal insulin analogs. So till today, we do have these 5 intermediate to long acting insulins. Possibly by the next year, mid 2024, we would be having once weekly insulin analog in India, but till date we do not yet have. Now amongst this is the entire portfolio. Rightly pointed out back in 1946 when NPH was discovered, and last about a decade ago glargine U300 got discovered, that the entire evolution of the basal insulin analogs. And as we could see here, that NPH being the first one amongst this has got a peak, and any insulin that has got a peak would carry itself a risk of hypoglycemia like NPH has got a half-life of around 12 to 16 hours. Then as we have proceeded more towards refined treatments, we had glargine U100, a more flatter peak with a time action profile around 24 hours. But the newer second generation analogs we are talking about, glargine U300 or degludec, even exceeds Glargine EU300 has got a half-life of around 36 hours, whereas degludec is even more. It tends to act about 42 hours per se, giving us the liberty of taking insulin in any time of the day, practically. With Glargine EU100, you need to stick to the time. You cannot go beyond 15 minutes change in its injection time. That's with Glargine EU100. Now, just as the house, I am not expecting much of an answer because we don't have a huge audience today, but these are two very, very important questions. People as we are treating physicians. How often do we witness hypoglycemia with Glargine? And the next question would be, how often we do witness nocturnal hypoglycemia with Glargine? These two are very, very important questions, because we do have an impression that Glargine, being essentially a peak-less insulin, is devoid of any risk of hypoglycemia. Well, that is not the case as it is portrayed. I will be showing my evidence, but this is not the case. Glargine causes hypoglycemia. Of course, it is much, much less than NPH or any other prandial insulins, but it is not entirely devoid of the risk of hypoglycemia. So, as we are discussing, is it worth the newer second generation insulin long-acting analogs, like I have said, Glargine EU300 or degludec? Do they come with such an advantage as to deserve such high cost? We will be discussing next. So, what are our evidences in favor of Glargine as far as the cardiovascular safety is concerned and the others? Now, regarding the cardiovascular safety of Glargine EU100, we do have a dedicated cardiovascular outcome trials named Origin, was published in New England Journal back in 2012, was taken more than 12,000 patients, pre-diabetics, namely impaired fasting glucose, impaired glucose tolerance, and patients with type 2 diabetes mellitus, and were followed for a median duration of around 6 years. So, it was shown that essentially, as opposed to standard of care, Glargine, as far as the MACE reduction is concerned, was CV neutral. So, the cardiovascular safety of Glargine was established beyond doubt. But there is more to it. In this one, Origin was a dedicated cardiovascular outcome trial. I would like to drag your attention to the lower part of our slide today. Even in that trial, it was shown that when compared to the standard of care, Glargine EU100 was associated with significantly more chances of developing hypoglycemia. The message is very clear. Although very, very less, Glargine is not completely devoid of the risk of hypoglycemia. This one is the outcome data of Origin, as we can see here on our left hand side. As far as the MACE is concerned, essentially it is neutral as the standard of care. So, the CV safety is established. Now, coming next, the comparison of Glargine EU100 and Glargine EU300. Well, evidence is strong. Edition was a group of trials. Edition 1, 2, 3 and 4 was a group of trials. They had compared insulin Glargine EU100 against EU300 in different subset of patients and different study population. The edition 1 was patients with type 2 diabetes mellitus on basal bolus therapy. The basal was 2, Glargine EU100 and Glargine EU300. And the median follow-up was about 6 months. The importance of this one was that as far as the primary efficacy outcome is concerned, that's the HbA1c reduction, there was essentially no difference between Glargine EU100 and Glargine EU300. Efficacy of both these insulins were same. However, there was a little more chance of developing hypoglycemia with Glargine EU100 as opposed to Glargine EU300. I won't discuss edition 2 and 3. Both of these were on top, basal insulin on top of the oral drugs. I'd skip to edition 4. Why is that? Because in the initial phase, our introducer had discussed that we would be discussing type 1 and type 2 diabetes today also with basal insulin. Edition 4 was with type 1 diabetes mellitus with pretty long duration of around 24 years. And the median age of those type 1 patients, remind you, was 47 years. So, they were very, very long duration of type 1 diabetes mellitus. With that, Glargine EU100 and 300 were tested with basal bolus regime. Essentially, again, as far as the primary efficacy outcome was concerned, meaning thereby the HbA1c reduction, there was no difference over a span of 24 weeks, roughly about 6 months. Another important aspect that come from edition 4 is there was essentially no difference between whether glargine is given in the morning AM or in the evening PM. Essentially, as far as the HbA1c reduction is concerned, none of these were better than the other. So glargine can be given in any of the time. Remember to give it fixed time of the day. But again, like edition 4, specifically in the first 8 weeks, hypoglycemia risk was slightly more with glargine 100 than with glargine 300. So that much is the difference, a slightly more chance of developing hypoglycemia in the initial phase. Efficacy wise, they were same. Next is a look ahead, meaning that this one is a first dedicated trial vis-a-vis degludec with glargine U300. Now this was published in Diabetes Care 2018. As the name suggests, there were more similarity than differences between these two insulins. Again, there was no difference as far as the HbA1c reduction is concerned, means efficacy wise they were the same, but in the initial 12 weeks period during the up titration, glargine U300 was having slightly less chance of hypoglycemia than degludec. That was the message. Now this one I am not going to discuss, that's a CV safety of degludec. So what's the point in glargine 100? It remains same because we are discussing targeted towards our Indian patients today. Glargine U100 has got a 24 hours action providing good efficacy as far as the HbA1c reduction is concerned. There is proven cardiovascular safety as we had already discussed. Origin got published in New England Journal back in 2012. Similar efficacy proven beyond doubt, and overall hypoglycemia risk is also similar compared to glargine U300 and degludec. And of course, there are options today of having a slightly lower cost in some of the biosimilar insulins that is available today. So these four are very, very important point if we discuss insulin glargine 100 today, because we do have our own limitations in Indian subcontinent. What are those? That's the harsh reality. Because in many of the occasions, if asked what could be more painful than the disease itself, many of our patients would tell it as the cost of the treatment. So these are the barriers of insulin treatment today. All of us are aware. Some are for the patient side, some are from our side. Our side, the mostly the inertia is important. We need to get rid of the inertia. But from the patient side, one of the major determinant of the barriers to insulin therapy would be its higher cost, specifically the analog insulins. Now this I have quoted from a 2020 article got published from AIIMS Rishikesh. A single center tertiary care teaching hospital, goes without saying. They tried to assess what could be the prevalence and the causes of primary non-adherence to insulin therapy in patients with type 2 diabetes mellitus. A small study, not a very big patient population. However, amongst the many causes that come up, one of the major causes was the cost of the treatment of insulin. And also there were some other points, but they are less important. This is from AIIMS Rishikesh, one of our dedicated centers. Now regarding the cost of the treatment, we do have some of the biosimilar insulins. This one is one of the Indian Journal of Endocrinology Metabolism article got published in 2019. One of my teachers, Professor Sujoy Ghosh, one of the lead author in this one. This is a nicely written review. Essentially, they have depicted everything that a physician should know. That mostly about 80% of the Indian population of diabetes patients pays the treatment cost from their own pocket. A significant chunk, more than 70%, possibly around 75% or more, is in the rural population, so the cost implications are even more. And India, also having a very high patient population of diabetes mellitus, spends very less from the government side. So the chunk of the cost burden comes to directly into the patient's pocket. So these are the realities. So in such given reality, despite having very good evidence of analog second generation insulin basals all, we do have a very good scope of insulin that comes at a lesser cost, but of course if it maintains very good quality, that would be a boon to our patients. Of course, as far as the standard definition goes, a biosimilar insulin, be it whatever, prandial or basal, should have clinically no meaningful difference in efficacy, safety or potency. So if that is maintained, the quality is assured and the cost can be curtailed, that would be a very, very good choice in Indian scenario. So with that I would conclude my session, that as we have discussed, that majority of our patients of diabetes mellitus, be it type 1 or type 2, do not maintain the adequately the HbA1c as is desired. Insulin remains a very, very important choice, specifically in type 2 diabetes mellitus, goes without saying in type 1, but it should be simple, the regime, it should be flexible, and of course it should be cost effective as far as Indian patients are concerned, because mostly we need to pay from our own pockets. And with that, although there is no denial of the fact that second generation analogs have got their own benefits as far as the reduction of hypoglycemia risk is concerned, but the difference being very small, and there is essentially no difference as the efficacy of the insulin is concerned, as the HbA1c reduction is concerned. But given all, biosimilar insulins does have a place, provided they maintain standard qualities. With that I conclude my session. Thank you so much for your patient hearing.
Thank you. Thank you, Dr. Kaushik. A very good and informative deliberation from Dr. Kaushik. Now, your topic was in Indian context. You
Yes,
have mentioned that biosimilar are very important in Indian context due to cost. Any other like high carbohydrate content or the difference in dietary pattern, timing of Indian context rather than the European one or American one? Is there any difference in those?
Sir, because we are discussing biosimilar, the longer acting basal insulins today, they do have a lesser role in the question you asked. Because we are more carbohydrate eaters, possibly the major difference would be with prandial insulins, means shorter acting insulin, they would be required more, or the drugs that acts more on the prandial glucose excursions like AGIs that sir was discussing a couple of sessions back. So shorter acting insulin or shorter acting prandial drugs would be more related in the Indian context, that is less related to the basal insulin or longer acting insulins.
Thank you.
Another comments from me, that when you just see the Indian patient there, most of the diabetic patients are suffering from the cardiovascular disease, and we just use this anti-diabetic drug particularly in terms of OAD, and if you compare the insulin, only the benefit of the insulin is only the hypoglycemic benefit, or you can say the anti-hyperglycemic benefit we are getting if you use the insulin, whether you use the basal insulin, first generation, second generation. But the thing is that when you just see the different guidelines, they say that after the 3 OAD failure, you have to apply the patient the basal insulin. So in Indian terms, what do you think that after the 3 OAD failure, we can add the fourth one? Because the OAD, and if you see these OAD of different types of OAD, like you can see the SGLT2 inhibitor, oral GLP-1, is available, and also the DPP-4 inhibitor. They are giving you the pleiotropic benefit in terms of the extra glycemic benefit. So what do you think about after 3 OAD failure, you will directly go to the basal insulin, or you can add the fourth one, which is much relevant in Indian context?
Sir, first of all, regarding the oral anti-diabetic drugs, like the drugs you mentioned, the SGLT2 inhibitors or DPPs, SGLT2 inhibitor for most of the diabetic patients are not given in third or fourth place. For most of the diabetics, it's given first, possibly even before metformin, as the guidelines are evolving over the past 5-7 years. So they are the first. So you have already given the pleiotropic benefits, you are already given the CV safety benefits to our patients, SGLTs, and second one possibly, if we keep apart metformin, other than that the DPPs or possibly the oral SIMA, that has got controversies again. So after that what remains is the SUs. Now most of the guidelines, even today, if we keep apart RSSDI, places SU towards the last. On top of it, you have, if you have a resource poor setting, if you have cost that is being a major determinant, then and then only you can add the sulfonylurea. So before that you have already given the major drugs that have got pleiotropic benefit other than glucose lowering. So possibly this holds true, that if we have an HbA1c of 8+ with 3 standard oral agents given in adequate dose, there is no point adding a second one or a fourth one. So it's always insulin, and preferably always a basal insulin, unless we do have other resource setting, when we cannot use basal insulin. But one important point just to mention, that most of the guidelines now suggest after weight is the first injectable should be a GLP-1 receptor agonist and not insulin. May seem a bit odd, but that's reality. ADA mentions that first injectable should be an injectable GLP-1 and not insulin.
Any question from the audience? Otherwise, I conclude the session. So, if there is no question, I conclude the session.
Thank you. Thank you so much. Thank you.
Thank you.
Thank you, sir. It's time to felicitate our speaker. I would like to request both the chairperson to please felicitate him.